I'd like to introduce our next speaker. Our next speaker is Dr. Marilyn Karam. Dr. Marilyn Karam will give us a talk on a topic titled The Impact of Comorbidities on the Management of Asthma. Dr. Karam graduated with a degree of Bachelor in Science 2005 and Doctor of Medicine in 2009, both from the American University of Beirut, and then completed her residency training program in Michigan at Henry Ford Hospital in Detroit, Michigan. And then she did her fellowship in allergy and clinical immunology at the University of Michigan Hospital. And Dr. Karam has practiced after her training in Lebanon at the American University Hospital of Beirut for the past 6 years, where she also served as a director of the internal medicine subspecialty clinics, which is her other hat. She has published several articles in renowned peer-reviewed journals and continues to be an active member of several allergy and immunological societies around the world. Dr. Marilyn, it's a pleasure and honor to have you with us today. Thank you very much.
So thank you for the presentation, and I'll try to keep it short and to the point. Switching gears back to asthma. So we're going to be talking about the impact of comorbidities on the management of asthma. I have no disclosures, and I'm obviously not going to go over all the comorbidities. I'll just go over a few that I chose to focus on. So most of the patients with asthma can achieve the goal of well-controlled asthma. But some patients with asthma will not be controlled even if you do everything right. And while most difficult to control asthma may have an actual severe disease, in many cases you can find modifiable factors which you can identify to achieve better control. And those include incorrect inhaler technique, poor adherence, smoking, comorbidities, and sometimes even incorrect diagnosis. So what is the prevalence and implications of comorbidities? We've seen a lot of numbers for our region, but in the US, 54% of patients with asthma will have at least one non-respiratory comorbid condition. Similarly, in the UK, the numbers match with 63% of adults with asthma with at least one comorbid condition. And the number and prevalence of comorbid conditions just increase with age, which is a real problem with aging populations all over the world. It does cause comorbidities in general have a high economic burden with substantial healthcare cost that is 5 times higher than the cost attributable to asthma alone. We know that comorbid conditions are also associated with worse asthma-related outcomes, increased risk of work disability, and significant productivity losses. They can complicate the diagnosis and management, sometimes leading to misdiagnosis, sometimes leading to under or over treatment. So we know that all the guidelines actually emphasizes confirming the diagnosis of asthma when you're dealing with a severe asthmatic. And they also mention addressing contributory factors and comorbidities before you even try to phenotype the pattern of inflammation. And so I think we need to address every single time we're faced with a comorbid condition, you need to address a few questions, which is basically how common are these comorbidities in difficult asthma? To what degree do these comorbidities contribute? And does the treatment of this condition improve the control of your asthma? And how should we clinicians evaluate and address these comorbidities? When we think about comorbidities, you can classify them into airway related or airway unrelated. There's a lot of comorbid condition. This is a few of them, but it's also important to note that some of these comorbid conditions come together, such as, for example, obesity, which will present with obstructive sleep apnea and reflux at the same time, so making the whole situation a bit worse. The first thing I want to talk about, and it's the most common thing that you're all familiar with, is allergic and non-allergic rhinitis. And rhinitis is extremely common, and the prevalence varies because of lack of standardization in how we diagnose rhinitis. But in the UBioPret cohort, so the unbiased biomarker in prediction of respiratory disease outcome cohort, it was noted that allergic rhinitis was present in 55% of severe asthma, 60% in non-severe. Similarly, non-allergic rhinitis was present in 15% of severe asthma and 11% in non-severe asthmatic. So allergic rhinitis is also underdiagnosed. And that's mainly because patients are used to this normal. They're used to having this nose blockage, and they underreport their symptoms. And sometimes there's also poor recognition of rhinitis symptoms by physicians, especially when the presenting symptoms are not the typical ones, and it's more of fatigue and cough. So in a study in the US, for example, 53% of children with asthma and comorbid allergic rhinitis remained undiagnosed until the actual time of enrollment into the study. Similar rates of underdiagnosis have been reported in adults as well. So evidence clearly supports a link between upper and lower airway, and you're all familiar with the unified airway hypothesis. Allergic rhinitis is accompanied by lower airway dysfunction. There is bidirectional talk between upper and lower airways. We have studies that show that segmental bronchial challenge with grass pollen allergens will induce allergic nasal inflammation. And in general, we have a generalized hyper responsiveness of the airway, both seen in allergic and non-allergic rhinitis. So what's the impact on asthma? We know that there's poor symptom control and quality of life, but it wasn't really associated with greater exacerbation frequencies. We also know that the longer duration of rhinitis, the greater the severity of the rhinitis, and sensitization to perennial versus seasonal were all associated with either greater airway dysfunction or more severe asthma. And again, both allergic and non-allergic rhinitis are independent risk factors for obstructive sleep apnea, which can even complicate the picture. So does the treatment of rhinitis improve asthma? We have the ARIA guidelines, which recommend the intranasal steroids for the treatment of allergic rhinitis. But we also know that the use of intranasal steroid is associated with improved asthma symptoms, quality of life, and decreased asthma-related hospitalization and ER visits. This is only true in patients who are not receiving inhaled corticosteroids for their asthma, so in mild intermittent asthma. We also know, which this was a bit presented in Dr. Gupta's talk, we also know that we have allergen-specific immunotherapy for the treatment of allergic rhinitis, which has durable effects. It actually can modify the disease itself. And it is included in the GINA guideline for step 2, step 3, and step 4. It's included as sublingual immunotherapy for dust mites just because, and that's my personal opinion, because most of the studies were done on dust mites. It will probably include all immunotherapy in the future. So immunotherapy has shown to improve asthma symptoms and reduce bronchial hyperresponsiveness irrespective of the presence of allergic rhinitis. But the caveat here is we cannot start it in uncontrolled asthma, and it's an absolute contraindication, especially for subcutaneous immunotherapy because of the risk of anaphylaxis, because asthma is an independent risk of fatal anaphylaxis by itself. This is a study that I thought I'd share. This is looking at the real world long-term effectiveness of allergen immunotherapy, which was published in Lancet in November 2021. They looked at approximately 46,000 patients who were treated with allergen immunotherapy. 15,000 were included in the pre-existing asthma cohort. And across the board, we saw that allergen immunotherapy was associated with greater reduction in allergic rhinitis and asthma prescriptions, including both asthma controllers and reliever prescriptions. There was also a significantly greater likelihood of stepping down asthma treatment, which was very significant, and a greater reduction in severe asthma exacerbation as well. The second comorbid condition is chronic rhinosinusitis. And the prevalence ranges from 22 to 42%. It's even higher at 50% in severe asthma. Nasal polyposis increases with asthma severity and is associated with a more severe phenotype. So 4.8 in mild to 45 in severe asthma. And when we're talking about nasal polyposis in the setting of asthma exacerbated respiratory disease, which is what we used to call Santer's triad, the pooled prevalence is 7.2% in all asthmatics, but it's even more common when we only look at severe asthmatic at 15%. We know also that treating chronic rhinosinusitis with nasal polyposis with all the different biologics listed here, so omalizumab, mepolizumab, and dupilumab, all improve subjective and objective assessments, including nasal symptoms and polyp size. And we'll have a talk talking about these three different biologics in terms of asthma, how they improve the outcomes. We also ask the question, can surgical intervention improve the outcomes as well? So here's a meta-analysis of 22 studies, basically showing that overall asthma symptoms improve in 76% of patients. There's decrease in frequency of asthma attacks, hospitalization, and ER visits. As well, oral steroid use was decreased by 72%, and inhaled steroids by 28%. This is a comorbidity that's dear to my heart, as I had a patient who was 6 months pregnant, seen by different physicians, diagnosed as asthma, and then that led to actually losing the pregnancy as a recommendation because the pregnancy was worsening her asthma. So vocal cord dysfunction is basically it's a mimicker of asthma. The diagnosis is extremely challenging. Direct visualization of the vocal cord is what we want to do, but it's also, it can be completely normal between attacks. So what happens here is there's an abnormal adduction of the vocal cords during inspiration. So instead of opening like the first picture that you see here during normal inhalation and then closing nicely, like the second picture during normal phonation, you will see the diamond-shaped picture that you see in the third picture during phonation. So instead of opening, the vocal cords are closing during inspiration. And the interesting part is that these attacks are provoked by similar triggers, including respiratory and laryngeal irritants, exercise, but it's different because it can also be triggered by stress, anxiety, and even frequent inhaler, which we give these patients, can trigger these attacks. The symptoms are very similar, so the patient will complain of wheezing, sometimes even audible wheezing, chest tightness. The difference is they do complain of hoarseness, dysphonia, and the globus sensation. So that should be one of the triggers for you to think about this. If ever in doubt, you can use the questionnaire called Pittsburgh VCD Index. This is a four questions basically that you need to answer with a total score of 9. Anything above 4, the diagnosis of VCD becomes very probable. The treatment of vocal cord dysfunction is usually speech therapy. There has been some data about gabapentin and pregabalin, CPAP, and then some botulinum injection into the laryngeal muscles. Gastroesophageal reflux is another one that we need to mention. So GERD symptoms are present in up to 40 to 80% of patients with asthma. And when we look at the objective evidence of manometry, pH probe manometry, it's also similar results with 62 to 72% in asthmatic. It is more frequent in severe asthma. So it can go up to 41 in severe asthma versus 15 in non-severe asthmatics. Looking at a review for proton pump inhibitors used in patients with confirmed asthma and reflux, that showed a significant but small benefit on the morning peak expiratory flows, but no significant benefits on other asthma outcomes. And according to the GINA guidelines, reflux should be considered as a possible cause of dry cough However, there is no value in screening patients with uncontrolled asthma for reflux. And the benefits of PPIs appears to be limited to patients with both symptomatic reflux and nighttime respiratory symptoms. I'll finish off talking about obesity, which has become a very big problem worldwide. It is an epidemic in the Western population with a prevalence of 36% among US adults. The prevalence of obesity in a European study was up to 18% in non-severe asthmatics, but it can go up to 40% in severe asthmatics. And a specific obese phenotype for severe asthmatics has been identified in both UK and US cohorts, but not in Asians, where obesity rates are much lower. Obesity is an independent risk factor for childhood asthma and wheezes, and particularly in females and girls. It is associated with poorer asthma symptoms control, poorer quality of life, and frequent exacerbation. And then when you look specifically at the waist circumference and waist height ratio, that also predict worse symptoms. So the reason why asthma is more difficult to control in obese patient is due to several factors, including the type of airway inflammation that we see, which is more a neutrophilic inflammation. So the heightened adipokine levels that act directly on epithelial cells and the high fat, high trans fatty acid meals also increase airway neutrophilia and impair bronchodilator recovery. The other reason why obesity can affect asthma control is that because usually it comes with obstructive sleep apnea, reflux, and depression. And there's also some mechanical factors. So obesity can lead to lower functional residual volumes to start with, lower tidal volumes, and lower inspiratory capacity. Also, obese patients have corticosteroid insensitivity, and that's because of what we call MKP1, which is mitogen activated protein kinase phosphatase 1, which is a key molecule by which steroids inhibit pro-inflammatory genes. So with increased BMI, we have decreased MKP1 function, so steroids don't do their job properly. Weight reduction should be included in the treatment plan for obese patients, and that's evidence B according to Gina. Increased exercise alone appears to be insufficient, so you actually need the weight loss. And the weight loss can improve asthma control, hyperresponsiveness, health status, and reduce medication need. But the most striking results have been seen with bariatric surgery, with even 5 to 10% weight loss making a huge difference in asthma outcomes. And the beneficial effects were dependent on the magnitude of weight loss. I will conclude with these actually 2 slides. This is basically a slide to briefly mention obstructive sleep apnea that affects asthma, increasing symptoms and decreasing quality of life, and CPAP or treatment of obstructive sleep apnea has shown to improve symptoms and quality of life. And a very important comorbidity is anxiety and depression, because most of these patients will present or confuse their panic attacks with asthma attacks. And then we do have studies that have shown that treating underlying anxiety and depression can improve symptoms and quality of life. So in conclusion, comorbid conditions can complicate asthma management in multiple ways. They can be part of the same pathophysiological process, such as rhinitis, or they may mimic and exacerbate asthma symptoms such as reflux and vocal cord dysfunction. And sometimes comorbid conditions may affect asthma therapy, which I did not mention. So sometimes you have a diabetic patients where you can't really give them oral steroids for their exacerbation. So that can impact your treatment. And sometimes even treating comorbid conditions, such as in cardiac patients, you give them beta blocker, that may affect as well your asthma control. So evaluating difficult asthma should always incorporate a meticulous search for these comorbidities. And sometimes actually using the screening questionnaires that are available to us can help if we basically get ourselves in the habit of being systematic into our approach for the asthmatic patient. These are my references, and thank you.